5-year-old child has presented with the complaints of abnormal behavior for the past 4 months, sir. Patient had the informant is mother, sir, whose reliability is good. The initially history started in January first week at around day 10th January 10th, sir. At the patient while was going for sleep after food, the patient had suddenly abnormal behavior in the form of a vacant stare. She was staring to both left side and right side, and had no verbal response, and was not there was a loss of touch with the environment. Whatever the mother and grandmother tried to call her, she was not responding to anything, sir. And they tried to give her some chain and things, and she was just looking at the chain and behaving abnormally and doing some impulsive movements with the chain, sir. Otherwise, there was no stiffening of limbs. There was no versus head movement to one particular area, side, and there was no tongue bite, frothing of mouth, or urinary incontinence, sir. They took her to hospital in and from there by 30 minutes or so this abnormal behavior settled down, and child became back to near normal, sir. So they kept her for 10 to 15 days in hospital, sir. Initial 10 days, the child was having episodes of restlessness. She would suddenly become irritable, want to get out of the bed, go run, and she would not uh, listen to their parents, and she would have a impurposeful movements, sir. There was no history suggest of any seizures, sir. And the last 5 days, the patient had stereotypical movements with the loud cooing noise. She would suddenly get up, do some particular repetitive movements. Again, she would stop, and associated with that, she would just make some cooing noise. And these episodes were lasting for about 10 to 30 minutes, and there were about 6 to 7 episodes per day. The more than 6 to 7 episodes per day, sir. This was happening in January, sir. And they were treated in a hospital for till 15 days. Then they were discharged, and she was continuing to having these episodes till now, sir. Prior to this event, on January 10th, 2 weeks prior, patient had a history of low-grade fever, 2 days alone, sir. That too, that was not associated with any cough, cold, skin rashes, or joint pain, sir. There was no other history of headache, vomiting, or altered loss of consciousness, sir. And till now, the patient has a repetitive stereotypical movements, sir. The stereotypical movements, like she would suddenly walk on 4 limbs, and or suddenly jump like a frog and go to each place, sir. This would last for 10 to 30 minutes, sir. She would not at all talk with anyone, just make cooing noises, sir. After that, she would become normal. In between, she would become normal. She would talk normally, use a mobile phone, or draw with her draw in her book, and talk with the parents, and there was a normal sleep pattern. Sleep was normal during all these 4 months, sir. There was no history of any sudden sweating or hypoventilation spells. There was no history of any other abnormal stiffening of limbs, contractions of upper limbs, or involuntary urination or frothing of mouth during all these episodes, sir. There was no history of suddenly getting up from sleep with sudden sweating, vomiting, or any other autonomic symptoms. No symptoms was not there, sir. There was no other history of any weakness of limbs, sir, and there was no history of any symptoms suggestive of cranial nerve involvement also, sir. There was no history of any unsteadiness of gait while walking. Normally, while you are walking, there was no history of any unsteadiness of gait or the clumsiness of hands while taking food to the mouth, sir. So this was the presenting history, sir. Natal history. Patient perinatal born of LSCS, term delivery. It was LSES was done because of reduced fetal movement, sir. And she had a low birth weight, 1.7 kg during birth, sir. There was a doubtful meconium stain aspiration. She was kept for 2 days in NICU, but she cried soon after birth. But she was kept in NICU for 2 days just for observation. There was good cry and good sucking, sir. She was exclusively breastfed for the initial 6 months, sir. And during the neonatal period, she did not have any history of any seizures or any recurrent NICU admissions, or there was no history of any jaundice, sir. Then during developmental history, they are saying till now it is all normal, sir. She head control was at 3 months, and she started sitting by 6 months without with support, and within 1 year itself she started walking, sir, and she started talking by using bisyllables by 1.5 years, sir. And she was and she now also she was used to scribble.
Just to interrupt, it is not bisyllables by 2 years. 2 years means 2 word sentence.
Okay.
Sentence. Bisyllables are they say by 7 months itself.
Oh, okay. Mama, dad. Okay, sir. And now she's able to scribble in her notebook. She's able to draw, able to dance, and she's able to walk on her own. She's able to feed by herself, sir, and she's able to tell ABCDs and poem and all by herself, sir. She was going to school in LKG, sir. By in September 2022, by that time or 2 months, she had some urinary incontinence problems, sir. She would wet her clothes while in school itself, sir. She was consulted in a nearby hospital, and after which 2 months, few weeks later, she improved, sir. They have planned to send her to school in UKG, sir. Till then, she was in home only, sir. And she used to play with her peers and communicate well with the family members also, sir. And vaccination, she is now vaccinated up to date, sir. And family history, she is born out of a non-consanguineous marriage. She is the first child, and the father's sibling had a history of doubtful seizure at the 3 years of age, sir. Father's younger sister, sir. And there was a early premature death in a father's family, sir. Father's sibling, one died at the third day of life, sir. The cause was not known, sir. So to summarize, I'm sorry. So to summarize, a 5-year-old child who was who had normal development up to age, sir, presented with prior history of fever 2 weeks back, 2 days. After that, 2 weeks later, patient had started having behavioral abnormalities and stereotypical movements, and reduced in during these episodes. There was a history of reduced language output, sir.
Okay. So, from the history, what all things you have inferred, and others, any other points to add, or you have anything else to contribute? Any doubts? Reddy, Reshma, Jasim is pediatrics. Mohammed Jasim.
Yes, sir.
You are from pediatrics, huh?
Yes, I am from Pediatrics.
Okay. Aparna was there. Is she there now? Again, pediatrics, Vishnu. Okay, so anything you want to add? Or any doubt, questions? Okay, so Reddy, what is your Arun you want to discuss?
Sir, a patient had abnormal behavior. It is very intermittent, sir. So it could be seizures, sir.
No, because see, in the tell. Okay, because there was a time onset in this case. Actually, you have given an exact date of onset, isn't it? January 10th. So whenever there is an exact date of onset is there, we'll start from there. Usually, what are the conditions that you can think of? Usually,
Sir, acute onset, it could be a vascular event at that particular episode.
okay, very good. Then
sir, it could be first step infectious processes and
what about the post-infectious?
yes, sir. Post or para-infection, post-infection, and
Yes. Again, demyelinations also can present almost in a sudden onset, acute onset. Okay, then so you may be remembering my mnemonic of WIT, isn't it? Whenever so along with that you remember vascular, infectious, post-infectious, and toxins, metabolic, isn't it? Because metabolic disorders also can present in that manner. And then seizure. Seizure itself becomes an acute manner, because acute condition. And in this case, there was an alteration of sensation, so recurrent altered sensorium conditions that can lead to recurrent altered sensorium. Okay, so those things also you have to consider. That is the first and foremost thing which comes in an acute manner. Following that, what else you had?
Following that, she had
isn't it?
yes, sir. She would not talk. She would just make some cooing sounds and have stereotypical movements.
Okay, she lost her speech. That was their next symptom. So when the speech is lost, what are the conditions that you have to think of? So we'll keep each one as a template for our discussion, and finally from each group we can take different conditions and make a different diagnosis. What is the next? So when there is a loss of speech, what are the first of all, what are the situations that you will think of?
This is a loss of speech, sudden onset, acquired aphasias.
It can be aphasia. It can be aphasia. Okay, then?
It could be dysarthria, or
it can be extreme form of dysarthria. Loss of speech should be a complete loss, isn't it? And you can call it as an anarthria. That means dysarthria or anarthria. Okay, then
hypophonia.
Yes. Then a stage of mutism, mutism. Mutism also can be there, because unlike dysarthria means it can be, what are the types of dysarthrias,
It could be
lead to anarthria.
Human or element type of dysarthria, sir.
Very good. Human or element. And human, can you get human dysarthria?
Human dysarthria, if it is due to some stroke, acute stroke, or involving the cranial nerves.
Is it so? Cortical dysarthria. If the cranial nerves are involved, then it is not a cortical dysarthria,
Okay, so pseudobulbar.
Cortical dysarthria, isn't it? Cortical dysarthria, which can lead to severe. If it is severe, then again anarthria will be there. Cortical dysarthria, isn't it? And because a sort of a speech apraxia, when there is a pericephalic lesions are there. So in adult we use the term foid, salicu, and or a Mary-Foy syndrome, isn't it? Where again a perisylvian cortical lesions, because with the opercular syndrome can lead to
apraxia of speech will be there in opercular.
Apraxia of speech. Then coming to the, as you said, it can be in the subcortical dysarthria can be there. Subcortical, for example, thalamic dysarthria and perisylvian, otherwise also it can happen. And then lower motor neuron dysarthrias, what are the types of dysarthrias? You have another spastic dysarthria when there is a bilateral pyramidal tract is affected as a
due to pseudobulbar effects.
Yes. Then coming to the lower, so these are the upper motor neuron. Then there are lower motor neuron. So which are the types of lower motor dysarthria?
Lingual, labial, guttural.
Very good. Lingual, guttural, or labial. So how do you differentiate, first of all, the dysarthria from aphasia?
Sir, in aphasia, there will be impaired comprehension or impaired repetition, impaired naming. In dysarthria, these will all be intact, sir. So only the quality of speech, the articulation will be difficult, sir.
Yes,
Naming,
yes.
naming, repetition.
So it is the language function that is affected in aphasia. Either it can be a comprehension or the motor, the production of the speech, or a combined one. So aphasia, in this case of is it so? Next question. So have you tried to differentiate whether it is an aphasia or a form of a complete form of anarthria or a mutism?
This was more like a complete form of mutism, sir. Except for these occasional cooing sounds, she would just become mute, sir, and not at all respond to anything. She would
But
just
what about her comprehension? What about her comprehension?
No, sir. At that time, she won't comprehend to anything, sir. She would just act on her own, sir.
So that means it is coming in an episodic manner.
Episodic manner, sir.
Oh, that means lots of speech was also coming in between. She is all right. She will not have any speech abnormality.
Yes, sir. And more like since it has been for the past 4 months, and it has been between seizure episodes.
Hello, can you hear? Because I think I am having a mild.
Sir, it could be seizure episodes occurring correctly in the temporal lobe. It could be for complex partial seizures, sir. Because of that, she is having repetitive language.
You are telling about the acute event where a child is having a staring spell followed by gyrational movement and then loss of speech, where that is agreed. So how long each attacks were lasting?
Sir, it could be lasting for more than 20 to 30 minutes duration, sir. And sometimes even more, sir. They don't know, sir. It occurs multiple episodes per day, sir. More than 8 to 10 episodes.
That time. Then what happened later?
Yeah, it is still present, sir. They say episodes are still present, sir. Now, till now.
Same as it has started from the January onwards.
Yes, sir. But that bizarre moments are like now. Previously, she would just while in hospital, she was just getting up from bed, lying back, getting up, lying back.
See, you leave that. We'll come to the that moment of the months later.
Speech was like that. Speech was the same, sir. In between, she would what was present on January is still now present, sir.
So my question is that initially they noticed one ictus, one event.
Yes,
so
yes,
that at that time it lasted for how many minutes? First episode, and then what was the frequency and what happened to her in between? What was her state of consciousness and responsiveness in between?
These episodes should last 10 to 20 minutes, sir. And after that, in between, whenever asked for any food, she would tell, she would need food. She would say yes, sir. She would reply to those questions, sir, in between and all. And she would ask for phone. She would ask for other things also. During those spells, she would not talk anything, sir. She would just make noises, sir.
Okay, in the initial phase, you told that child was admitted in the hospital for almost 10 days.
15 days, sir. 15 days.
15 days. At that time, initially, how was she behaving in the hospital? Was she in a prolonged state of unresponsiveness, or a state of coma, or a state of altered?
There was no loss of consciousness, sir, and there was a state of altered mental status, episodes of altered mental status, and irritability, sir. Otherwise, in between, she would become normal and take food. That activity she was able to do, sir.
That means in between, will she be becoming fully communicative? Fully, will she become to her previous?
Not to the previous near normalcy, sir, but there will be a drastic difference between those episodes.
Okay, so we will consider that as a paroxysmal episodes with an impaired awareness and loss of speech, definitely. So it must be a definitely seizure with an impairment of awareness, isn't it? So
Yes,
that means probably it must be a focal impaired awareness seizure, or previously called as a complex partial seizure. Okay, so in between, you were telling that she was having a various stereotypic behavior.
Yes, sir.
How was that stereotypic behavior happening?
Initially, stereotypical behavior, just she would get up from bed, lie down, get up from bed, lie down, or she would just randomly look to side like that only, sir. Now, after that, she started jumping like frog, or walking on four legs, just crawling and walking like that. She would start walking. Suddenly, she would do that for some time. Again, she would become normal, sir.
In 10 minutes, this will end. Then immediately all of you can join with the same link. Okay, when it stops or abruptly ends. Okay, so we'll continue. Actually, so those episodes, I think you can, since the child is restless, not sitting quiet, what can you call it?
Sir,
All those, because just not only a simple stereotypic movement, because you can get stereotypic movements. What is called by a stereotypic movement?
It is a repetitive, impurposeful movements that are continuously action.
Yes, coming in a repeated manner. Also, and almost the same movement, because for example, hand flapping movement or a head rotation movement. But here, she is restless, she is not sitting, she will jump like a frog. So those behaviors, activities were coming in between. So what do you call that type of behavior? My perception is that condition, because that again was coming in some period of time, isn't it?
Yes, sir.
So usually we can call it as an akathisia. What is akathisia?
State of inner restlessness, becoming irritable. She has to move or else.
Yes. Akathisia means inability to sit still.
Can't sit.
Definitely, she was having an inability to still with an associated movement. The only thing is that in that akathisia, they will not be having a coordinate. Coordinate means purposeful activities will not be there. They will sit one place, then again they will move about to another place, and they will show a state of anxiety. But in this case, she was showing some type of that, as you said, each time she was showing that the frog jumping like that, isn't it? Anyway, definitely behavioral associated syndrome or a behavioral dysfunction can be considered. Being a child, we can't examine more cognitive dysfunctions at this level, unlike in an adult. Okay, so what else? So it is going on like that only. There is no improvement. There is no deterioration, or is there any improvement in between?
There is no worsening or no deterioration, sir. What she was there. That is the same status till now also, sir.
Okay, and she is getting. What is the frequency of that speech arrest and staring spells during that last 1 week?
At that time, exactly they don't know. They are telling more than 6 episodes per day, minimum at least 6 to 8 episodes per day. They are telling.
Okay.
Exactly, they haven't counted that, sir.
Okay. So any other symptoms she has other than these two things?
Other than that, there was a prior history of fever around, sir. Only what was
Agreed.
2 days low grade.
Agreed. And she had a enuresis in between earlier. Is that enuresis continuing or is she having a bladder control now?
Now, after that, she had bladder control. They are telling she has bladder control now, sir.
No, there is no nocturnal enuresis.
No, sir. In September 2022, around that time only, she had some enuresis during daytime, sir. And she in school she would wear
Is
clothes.
there any sleep? Is there any sleep disturbance?
No, sir.
Imbalance?
I asked specifically, sir. The sleep they are telling it is normal, sir. She would sleep at night and get up in the morning. There's no in between disturbances waking up from sleep.
Okay. To others, what are the other negative symptoms? We must be asking, I think, to Reddy itself can answer, because what are the other negative symptoms in this case that you will ask for going to get a diagnosis?
Sir, we can ask for any other autonomic dysfunction was there during sleep, whether she was getting up from sleep, vomiting, sudden sweating was there episodes, sir. Or is there any non-REM sleep like kicking the legs, or is there any somnambulism or striders during sleep?
Okay. Is there any sort of behavior, any sort of hyperexplasia or pain syndromes, any sort of pain syndromes they are complaining?
No, she doesn't complain of anything like that, sir. Cramps.
Okay. Now, coming from above downwards, is there any symptoms of a raised intracranial pressure?
Raised ICP. Headache or recurrent vomiting was not there, sir.
Not there. Any cranial nerve symptom?
No, sir.
Okay. Any limb weakness or a limb power loss?
No, sir. No focal lateralizing symptoms, sir. No, there was no weakness, sir.
Okay.
Clumsiness of hands, sir. Nothing else.
And no ataxia, isn't it? And
No,
what about any systemic symptoms? We have to ask for systemic symptoms also. Any systemic symptoms?
No B symptoms of fever, chronic fever, weight loss.
Okay, it's almost 5 months. She didn't have any fever in between.
Only 2 weeks prior, she had 2 days fever. So that too,
that's great. That is before January 10th, you know.
Yes,
from January 10th to this May 20th, is she not having any episodes of fever at all?
No, sir.
Did they complain of any episodes of fever? And is there any worsening of the symptoms with fever?
No, sir. There was no history of fever till after that, sir.
Just ask them whether there is any worsening with fever.
സംഭവം ഉണ്ടല്ലോ ജനുവരി വീണ്ടും പഠിച്ചിട്ടുണ്ടോ ജനുവരി ഇപ്പൊ ഇതിന് കാഴ്ചയിലുണ്ടോ ഫീവർ ഉണ്ടോ ജനുവരി തൊട്ട് ഇപ്പൊ വരാ ഇല്ല പഠിച്ചിട്ടില്ല. No, sir.
And no worsening, just going on like that only, isn't it? Yes, okay. Sir. What about her social behavior with the others?
She's hitting her start hitting. Become sir. And but she's maintaining eye contact while talking. She would just become mute while talking, sir. And while in hospital and doing what also, she would suddenly run our part or go everywhere. And if older, she would start hitting the mother or father. But in between, she's normal. She would just use a mobile phone or just scribble. She would just dance and talk something and all she's doing, sir. Whenever when she thinks she's being noticed, she starts doing these abnormal behaviors.
Okay, so see, when a normal child around 5 years deteriorates, we will have to think of various conditions. So now we'll think of certain conditions which will help us to ask for further findings also. What are the specific conditions in this situation that we can consider? First, you localize, and then we'll think of the disorders.
Localizing this to encephalon only, sir, because there is no other focal deficit, and this is it could be diffuse encephalon involvement. There is no localizing, no cranial symptoms. There is only behavioral abnormality and language problems.
Okay, behavioral abnormalities. But so behavioral abnormality, whenever when a person is having a behavior, you can see here this child is having severe hyperactivity. She is not sitting quite.
Not able to sit in one place or be silent.
Yes, sir. She is having severe hyperactivity, not sitting quite at all, and definitely hyperactive. And then, as you said, the other behavior abnormalities. So, for behavior abnormalities, is it always solely the abnormality will be in the cortex?
It could be in basal ganglia also, sir.
Just like we tell that once
limbic system.
Ataxia or a movement abnormalities. For ataxia, we may say that the abnormalities in the cerebellum or its connections. So here also it can be in the cortex or its connections, which are the three behavioral pathways that are important in modifying our behavior. Three important. Actually, there are five connections which are cortico, basal ganglionic connections, and other which are five pathways are there. Among them, which are the three important behavioral pathways that can lead to this sort of a behavioral abnormality.
Sir, the limbic system and frontos.
Okay, so what are the other autoimmune disorders? Because not that common in children, but which can occur in adults, other than NMDA encephalitis, and what are their manifestations? What about what is the common manifestation of LG I1 encephalitis?
Sorry, don't know, sir. Don't know, sir.
LG I1, you don't know. Usually it happens in elderly, because usually the frequent they will be having a focal motor seizures, amnesia, and many times they will be having an associated hyponatremia also.
Okay.
Almost related, because they are all BGKC related autoimmune encephalitis. Similarly, you must be having the Casper2 related autoimmune encephalitis also. What is the manifestation in Casper2 related encephalitis? Casper2. Okay. Again, it is commonly, unlike an NMDA receptor encephalitis, which is more common in females, this one is more common with the males. They can have a neuropathic pain, cramps. Again, encephalopathic features will be there. Along with that, they'll be having frequent sleep disturbances and the facial-brachial dystonic seizures. What are the other encephalopathy means the antibodies that are implicated in the
GABA A, GABA B, sir. Then
GABA A, what is the manifestation of GABA A encephalitis? Each
one I don't know. Specifically, each one features I don't know.
Actually, always we are discussing autoimmune, isn't it? By now you'd have diagnosed. I don't know whether how many of them would have been correct, but you'd have diagnosed at least some 10-15 autoimmune encephalitis by now, isn't it? So after seeing each encephalitis, you try to read. Okay. What is the manifestation if it is a glycine receptor encephalopathy? Just think of a glycine receptor encephalopathy.
No idea.
What anyone else? Can someone just deduce the symptoms in a glycine receptor related encephalopathy? Can anybody deduce? Have you heard of any syndrome associated with the glycine receptor mutations? Why pediatricians must be knowing. Aparna or Jasmine now gone, I think he's not there. Anybody, you see syndrome of hyperexplexia, hyperexplexia syndrome in newborns. It is a glycine receptor mutation, hyperexplexia syndrome. And in older children as well as in adult, because glycine receptor related encephalopathy can occur at any age. Mainly, it will be manifesting the brainstem features because glycine is in the subcortical or spinal cord level, Because of that, they'll be having more of a brainstem manifestations, rigidity, hyperexplexia, confusion, all these things will be there.
Okay.
And so that means whenever there is a hyperexplexia, so there is another type of antibody related syndrome is also, that is DPPX or a dipeptidyl peptidase protein related disorder, DPPX or dipeptidyl peptidase like protein. That is here again you will get a myoclonus. Then hyperexplexia is also manifest. So hyperexplexia syndromes you can remember as glycine receptor encephalopathy and DPPX syndrome, DPPX encephalopathy. These are the two one. Okay. And which are the encephalopathies? Here again only we did not get any sort of an orofacial dyskinesia. Is there any orofacial movement?
No, sir. No, sir. No, sir.
Any sort of a
movement? No coriform, no any involuntary movements, or no lip smacking, no other movements. So oral movements.
Okay, so what she had a sort of a seizures, predominantly seizures, the behavioral modification. So which are the syndromes with autoimmune syndromes with seizures? Again, you are not. Anybody others also? Your seniors have enjoyed, isn't it? I think they all have completed. Okay, you are the seniors now.
Epileptic encephalopathies will be presenting.
Okay, epileptic encephalopathy we can think of early developmental and epileptic encephalopathy, DEE. Okay. But usually that sort of a condition can be considered. That is a progressive myoclonic epilepsy syndrome, isn't it? That possible. That is a separate entity, progressive myoclonic epilepsy or progressive myoclonic encephalopathy. Almost similar presentation you can get, but what will be the third symptom that should be there in such a condition? It is seizures. She has some sort of a behavioral changes or a dementia, and they have ataxia.
Okay,
as progressive myoclonic encephalopathies will have seizures or myoclonus, ataxia, and dementia. So whenever there is an altered behavior, seizures, you can think of various progressive myoclonic encephalopathies. We'll come to that. I was just concluding various autoimmune disorders, autoimmune encephalopathies with the seizures as a manifestation. Again, NMDA receptor encephalitis, because many of the NMDA receptor encephalitis in children, I have seen they're presenting starting with the seizures. Second, LGI1 encephalopathy can have frequent focal seizures. Then you must know that GABA A and GABA B, because they are GABA A and GABA B related disorders, definitely they can have seizures as a manifestation. And in that also GABA A receptor encephalopathy can have a status epilepticus as a manifestation. But GABA B, again with presence with an impairment, intermittent seizures, but encephalopathy with an impaired memory is a very, very, very common manifestation. Okay. So we can think of different autoimmune disorders. Whenever there is a seizures is there, movement disorders are there, hyperexplexia is there, brainstem manifestations are there. Okay, so we'll leave aside. So among them, this is not having a typical NMDA receptor encephalopathy, because usually they will
no autonomic fluctuations or no hyperventilation spells are not there, sir.
And again, by this can definitely choreothetic movement, dystonia, choreothetic movement, all will be a very important manifestation of an NMDA-related encephalitis. For others, usually it behaves with a flu-like illness, followed by the psychiatric manifestations or behavioral manifestations. Then they go into a state of hyperkinetic because they'll become agitated. Then they develop the abnormal movement in the form of orofacial dyskinesia. They may have faciobrachial dystonic seizures and Parkinsonian features. So initially behavioral changes, hyperkinetic changes, then followed by this sort of a abnormal movement. So then they have the frank encephalopathy also can occur. That is the usual presentation of an NMDA. Here this child had a behavioral changes, some sort of an akathisia, now progressing to a hyperkinetic behavior. That means here the child has an hyperactivity. That is not quite at all. Okay. So anyway, we'll keep it there because there are some features, but it's not fitting with the autoimmune encephalitis. What is the next thing? As we have progressive myoclonic encephalopathy.
It could be Landau-Kleffner
presenting in this manner.
Landau-Kleffner syndrome, sir. Epileptic encephalopathy with aphasia, acquired aphasia.
Okay. Landau-Kleffner syndrome with the acquired aphasia. But in between, she is talking, isn't it?
Yes, sir.
She is normally communicating. Her comprehension is good.
Yes, sir.
Yes. What is the typical speech abnormality in Landau-Kleffner syndrome? Why others are not helping you? You are the only one who is answering. Okay. Anyway, answer.
Sir, typical. It is a. I read it as only aphasia, sir. That too associated with the EEG abnormality.
Anyone else from pediatrics or others? What is the typical manifestation of a Landau-Kleffner syndrome? You are always talking about Landau-Kleffner because it is a verbal agnosia. Verbal agnosia means initially they will not be able to recognize spoken words, but they will be able to recognize a phone bell being ringing. Like that, they can remember, they can understand. But later, they may go into a complete state of aphasia with an encephalopathic features. That may happen. But mostly so parents also will think that they are deaf because of this sort of a verbal agnosia. When their name being called, they will not respond. But so that is, but in this case, it is not the manifestation. Whenever she is called, I think she is responding, isn't it?
In between, she would respond. In between, she would respond.
She is responding. So it is an ictal aphasia only. Ictal aphasia is not a not suggestive of a Landau-Kleffner syndrome. In between also it should be there. Okay, then what else?
Initial manifestation
of epilepsy.
Could it be initial manifestation of autism spectrum disorder?
See, what we have to consider is SSPE. Will you not consider SSPE? Because in a child who presents with seizures, behavioral changes, you have to think of a SSP. What are the other manifestations of SSP?
Low myoclonus, negative myoclonus.
Usually, in the initial phase, they may feel as when the child is walking, they may fall down, fall back as if being pulled to. We have discussed
pulled back.
SSP, you know?
Yes,
Do you
sir.
remember we have discussed one case?
We had cases. I haven't seen
yes.
cases.
In that, what happens? There will be a sudden backward fall as if being pulled by a string. That is the. What about her? Was she writing? What about her handwriting?
There is no sudden throwing or jerking of jerking movements or not.
What I am asking is, what they will have a deterioration in the handwriting. Was she writing earlier and now has she lost that ability to write?
I didn't specifically ask for that, sir, but they told she is not going to school now.
Draw a circle? Is she able to draw a circle, square, etc.?
I couldn't test that now, sir. Currently, I couldn't test that now, sir. She would just scribble in the phone.
When you are testing the language, most important thing is to test the writing ability. Okay, being a 5-year-old child, whether if she was taught ABCD, because by 4 years, definitely.
Yes, sir. She knows ABCD, sir, and she knows poems also.
Is she writing now?
How she's not doing, sir? Whenever we go to examiner, she's not at all cooperating, sir. In between,
No,
the
but
family
you can
makes
you
videos.
can ask the parents. You can ask the parents to make a right.
Okay,
Okay,
sir.
you ask them to just give them a pen and pencil, and surely they can do it, and ask them to give it back to you. Okay, that
Okay,
is
sir.
sufficient. Okay, I think we will continue. The next thing is that so SSP, where you have to look for other manifestations also. Then what else? What other thing
Hashimoto's
you can?
steroid responsive to the Hashimoto's encephalitis.
What is usual? What is the usual age of Hashimoto's encephalitis?
That could be in adolescent age, and then there will be associated sleep disturbances and night.
Usually in an adolescent age, there again it can come in a waxing and waning manner. Waxing and there may be some evidence of a hypothyroidism also. It may be. Need not be there because only one testing only you may identify it. Very good. What else? Anything else? Because of this sort of a low, severe hyperactivity behavior, her loss of some amount of cognitive function also.
Autism.
So, have you heard of a childhood disintegrated disorder?
No, sir. No, sir.
Childhood disintegrated disorder. Actually, it is a form of autism spectrum disorder. Earlier, when we were differentiating or discussing autism spectrum disorder, the terminology used was pervasive developmental disorder. Among them, autism, then Asperger's syndrome, Rett syndrome, and this one, that this childhood disintegrated disorder. Or a Heller's syndrome, and then PDD-NOS. That means PDD-NOS means pervasive developmental disorder not otherwise specified. Okay, these were the conditions described earlier. Now we use the term ASD for everything. But among them, the child who is normal till 5 years, then deteriorates, loses the social cognitive function. Then we use with developing stereotypy and loss of a social contact. Then we use the term Heller's disintegrated disorder or childhood disintegrated disorder, CDD. So these are the conditions that can be considered. CDD. Okay. Actually, it is form of a autism spectrum disorder which occurs in a later age. Anything else you will consider? Because just like a paraneoplastic syndrome in adults, will you be considering because limbic encephalopathy like conditions? Paraneoplastic. Actually, it is very rare in children, but if just an adult, you would have considered that also. Any other conditions you will think of? I think our Presentor is there. Is there any other Presentor, your points?
Sir, I'm listening to
any thoughts?
Only thing is, you said that you considered rightly the previously normal child with a short duration acute onset, predominantly behavior problems. The pathological part, most likely fever triggering, it can be para-infectious, demyelination or infection as such is less likely. Another rare possibility of a fever triggering an inborn of metabolism, but that is unlikely. Because all these 5 years perfectly all right child, all on a sudden one episode only at this age, inborn of metabolism triggered by fever is less likely. The other entities, pathological.
Even though I did not go into that, at least one or two conditions we can think also. But only thing is that it may not be in this much acute manner, acute manner. But again, what are the two others? What will be the metabolic conditions we can think of when there is a dementia in a child? That means here
Lake syndrome.
Leigh syndrome is more of movement abnormalities of ophthalmoplegia, ataxia. But dementia as a major manifestation. It is Sanfilippo. Sanfilippo is one condition which can manifest almost in this manner. And there are dysmorphism. That means Sanfilippo is a MPS 2, 3, 4. 3 at the MPS 3. It will present with cognitive decline. And the other facial features, bony abnormalities, all will present later only. So you can think of that, but some amount of coarse facies must be there. By this we will have to examine. As sir, anything else? I have interrupted because I just thought of the conditions.
We need to consider is something we consider pandas and the streptococcal infections leading on to neurological problems all on a sudden. But this is not the manifestation of pandas, but there are some neurological features following these infections, autoimmune nature. Sometimes, rarely, whether Tourette syndrome need to be considered in like presentation, thyrotoxic situations and Tourette syndrome and all, but there are a lot many other features not fitting. The acquired manner, acute onset, the group of problems, of course, autoimmune comes in the 90% possibility. Other things, some nutritional disorder, deficiencies and poisonings. Acute poison situations, nutritional disorders, inborns of metabolism are the entities which need to be considered as a pathological basis in this case.
Yes. As I have already mentioned, our which because it has started as an acute illness and then continuing like that. So you have to think of a disease process that can start in an acute manner, then it is going on like that. Any other, but if you are considering any infectious process which is going in a chronic manner, chronic infectious illnesses, what all conditions you can think of other than SSP?
Neurosarcoid, I don't know. So, but then
Yes,
that one has cranial nerve involvement, anything that will be there. Sir.
Yes. Actually, neurobeshe you can think of. And
Syphilis,
even
neurosyphilis.
Lyme disease is another one which may have this sort of a presentation. Lyme disease. Anyway, so I think others, any other, what were your possibilities other than what I have mentioned?
And we considered one thing was autoimmune encephalitis, sir. And also the EEG, we have the EEG also, sir. EEG was MRI was normal, sir.
Okay, we'll go to the quickly do examination findings. Do you have anything additional in your examination finding? Just ask them to bring the camera once again. Let me see her. Ask them to undress her also if they don't have any. Undress her and we'll just her for a minute. അതിനെ മുന്നോട്ടൊന്ന് നിർത്തിക്കുക, എവിടോട്ടൊന്ന് നിർത്തിക്കുക. മോളെ ജസ്റ്റ് ഒന്ന് കാണട്ടെ, അവളെ ഒന്ന് ഇത് ചെയ്തോ, ഫോക്കസ് ചെയ്തോളൂ. അവിടെ ഫേസ് എല്ലാം ഒന്ന് ജസ്റ്റ് ഫോക്കസ് ദ ഫേസ് ടു മീ. Can you focus the face little more? Little more? Okay. But now it is, I think, getting blurred. No problem. Okay. Very good. ഇരിക്കട്ടെ അവള്. ഫേസ് ഒന്ന് കാണും. മോള് കൈയൊന്ന് നീട്ടിക്കേ. അവിടെ കൈയൊന്ന് നീട്ടാൻ പറഞ്ഞു. എന്തെങ്കിലും സാധനം കൊടുത്തേ അവിടെ കയ്യില്. ഇത് കൊടുത്തേ. മോള് കൈ നീട്ടി ഒന്ന് ആ പേന ഒന്ന് കൊടുത്തേ അവളുടെ കയ്യില്. മോള് പേന വാങ്ങിച്ചേ. ആ കുപ്പി ഒന്ന് തുറന്നേ. കുപ്പി ഒന്ന് തുറക്കാൻ പറഞ്ഞ അവളുടെ അടുത്ത്. മോളെ കുപ്പി ഒന്ന് തുറന്നേടാ. കുപ്പി ഒന്ന് തുറക്കാൻ പറഞ്ഞ അവളുടെ അടുത്ത്. കുപ്പി ഒന്ന് തുറക്കാൻ പറഞ്ഞേ. തുറന്നിട്ട് അടയ്ക്കാൻ പറഞ്ഞേ. ഒന്ന് തുറന്നേ മോളെ. കുപ്പി തുറന്നേ. വാങ്ങിച്ചോ. ഒന്ന് തുറന്നിട്ട് അടച്ചേ മോളെ. അമ്മ അത് അവള് വാങ്ങിച്ച് തുറക്കുവാ, തുറന്നടയ്ക്കുവാ. തമിഴാണോ അവര്? തമിഴാണോ? Very good. I think Dr. Firoz also has joined.
Hello, sir.
അതൊന്ന് ബൈ. ഓക്കെ. ഞാൻ അവളെ ഒന്ന് പിൻ ചെയ്യട്ടെ മോളെ. ഓക്കെ. ബട്ട് എനിക്ക് തോന്നുന്നു is she having a stooped forward posture? But she is so fast, isn't it? Unlike Parkinson in this thing. But she has a stooped posture. But she is very hyperactive always. Okay. അവളുടെ പേരെന്ന് പറയാൻ പറഞ്ഞേ അമ്മ. പേരെന്നാ? പേരെല്ലാം പറയുവോ? എന്താ പേരൊക്കെ പറയുവോ ചോദിച്ചാ? കേൾക്കുന്നില്ല. അവളുടെ ആവശ്യങ്ങളൊക്കെ പറയുമോ? Okay, Arun, Madhumari, Arun, have you done the higher mental function assessment of her?
I couldn't do higher mental function, sir. We tried to make her draw, tried to make her use any object answer, sir. She won't cooperate for that, sir.
But
And
what
in
about,
between,
first
we
of
took
all,
a
what
video.
about her language assessment? Have you done a formal step-by-step language assessment?
They have already tried assessment by psychologists, sir. They told to review once she's.
No. What I am asking is, have you done? What are the things you will use? First and foremost, is she saying any words?
Is a comprehension is a syntax or not, whether she is repeating words or not. And she in between they have videos also, sir. She's saying some poem and she's starting to dance that one also.
So when she is speak, that is,
See, in between she talks, she tells name of father and mother, everything she's able to tell, sir, and relatives and also. And all this she's able to name, sir, and repeating also she's able to do, sir. But fully how to do.
So so you identify her language capacity. If it is a single word, 2 words together, or is she able to tell full sentence?
Short sentence she is able to tell, sir.
So and what about her naming? Is she able to name objects in the room? At least some objects. Then comprehension, 1 step, 2 step, 3 step, 4 step commands. Because by 5 years means she must be able to understand a 4-step command. If it is not possible, see that is a single step command. Single step command means 1 year old. 2 years, 2-step command, 2 years. 3-step command, 3 years. Like that. Okay. This will end in 10 minutes. So again, you log in after 10 minutes. Okay.
Okay, sir.
Okay. So regarding the higher mental function, so ultimately, what is your comment about higher mental function?
Higher mental function, I can't make a label of it, sir. How to
she is severely hyperactive, isn't it?
Yes, sir.
She is very because even in in this situation itself, she is behaving in a odd manner and behaving in a very, very hyperactive manner. So yes, definitely sir. She has a hyperactivity. Okay, so and along with that, she must be having some sort of inattention also. So that attentional matrix and hyperactivity is there. Then any other neurological deficit you have noticed?
A plantar was bilaterally extensor, sir. Tested many times, sir, but it still extensor only, sir. Otherwise, reflexes are all just present, and there is no weakness. No other release reflexes are not there, sir. Plantar.
Tone also, any change in tone?
No, sir. No Gegenhalten or a rigidity is not there, sir. Tone is normal, sir.
Okay. So systems.
Other system, sir. Other system. There was no organomegaly, sir. But outside ultrasound, they gave mild hepatosplenomegaly. They are given to again. We have to recheck again later, sir.
Okay. So for want of time, you can tell Dr. Firoz, have you thought of anything, any contributions or any thoughts?
Sorry, sir. Actually, I didn't hear the full story. I just joined only. No idea.
Actually, whatever you are seeing is the manifestation, and she had one episode of seizure at January 10th. Following this, she is getting an episode of a staring spell, loss of speech, and then she is behaving like this. That's all.
So relatively
Nothing.
acute onset thing only. No?
Ah,
So
yes, yes.
before
Started
that,
as acute thing.
this sort of hyperactivity was not there before this.
No,
Ah.
sir. Before January, this she was not like this, sir. She
So
was a
anyway,
normal child, sir.
so it's an acute problem, no? So you have to consider all this autoimmune or an infective process or other inflammatory conditions like sarcoid, Lyme, all those things, I think. But it's a predominantly a behavioral issue, no?
Yes, yes. It's predominantly a behavioral issue. Okay, or a behavioral problem. But definitely she had episodes of seizures. That's a problem.
And the stereotypical activities.
Okay, so we'll see the what about EEG? Can you upload? I'll make you the host. I think Arun, Arun, I'll make a host.
Okay, sir.
So you can upload if EEG and other things. Let us see.
Sir, I have it in this system only, sir. Can you make MES as host, sir? MES.
MES is not there, you know.
Sir, MES neurology, that is
MES neurology is not logged in.
that is a main participant recording the session, sir.
But it is not seen. I'm not seeing. Let me see. Only now 8 participants.
Participant as disabled. Sir.
It's not seen. It's not seen.
Ah, MES, I saw, MES, I saw. I'll make MES host there.
Okay, sir.
You can, I think you reclaim the host. Can you make MES host? Just Arun, you can make MES host because since you have become the host, I can't change it. Ah, MES is the host now. Okay, now upload it. Okay.
Can you see this, sir?
No. We are not
No,
seeing.
it's not coming yet.
We are
It
not
is getting
seeing.
uploaded on.
You actually, you from the screen, you whole desktop you share whole desktop. Then
Hello. Can you see? Can you hear? See this, sir?
MES has started sharing screen, but we are not seeing.
But
Others
this
are
I
you seeing?
think I don't started share screen. It is coming, sir. It is still loading, I think, sir.
No, it is not like that. You just go to the. There may be different windows. You know, go to the other windows and see whether it is coming or not.
Okay, sir. I think system has stuck, sir. That's all. That is the issue, sir.
Okay. So, okay. What did you get anything?
Sir,
EEG?
there was a right temporal spike, sir. Central temporal spike, sir.
Definite spikes or just imagination?
So can you see this, sir?
You are showing in MES screen or Arun?
MES screen, sir.
MES, we are not seeing anything. Except the patient only.
1 minute, sir.
Anyway, Firoza, have you seen the EEG?
I don't remember. Arun, this one was reported by whom? I have seen it.
This is now only. Sir, can you see this, sir?
Oh, definite
Sorry?
definite spikes are there. Definite spikes are there. Okay.
This was
See,
taken this week, sir. Now.
Definitely it is there and coming repeatedly. So this is an epileptic syndrome, isn't it? So definite epilepsy is there. Okay, it is there. And that too confined to one side only, right side, isn't it?
Yes, sir. Right. Predominantly only right side, sir.
Right
MRI
side.
was normal, sir.
Okay. Diffusion, did you look at the diffusion also?
Sir, diffusion we have taken, sir.
Some spilled over to the left side is also there, isn't it?
I will
Predominantly.
share.
centrotemporal variety. So I
No,
think
there is left also.
you have
Left also is
suggested
there.
a variant form of or a malignant form
Now
of
sharing another EEG, sir. This was
this
taken
is
previously.
typical of a centrotemporal thing. See for see there. I'll just keep it there. Just keep it there. I'll just describe it. See,
1 minute, sir.
for the previous slide, you just keep it there. Previous one, previous page.
Previous.
Previous
1 minute,
page.
sir.
Previous
take it,
page.
sir.
For the pediatric people, I'll just show them. See, I will annotate it there. I'll annotate and people can see. I'll annotate, people can see how. Go to the just 1 or 2
This, sir?
just forward. Then only that the other EEG, you know, that white bright EEG was there.
White
Quickly,
bright. Oh, yes, sir. I'll share that, sir.
I think in 1 minute it will stop, but immediately all of you can rejoin.
Okay, sir.
You go to that other one, white page, just for the pages to medicine pediatric pages to see.
Can you see now, sir?
It is the now you go to the next page. This is the one. Next page. Keep it there. Keep it. Previous page.
Okay, sir.
Previous was better. Just keep it there. Keep it there. For all of you, see, this is the that is also okay. See, I will just annotate and show you the pages. See here. So this is the spike discharges you are seeing, and see here the common electrode is C4. C4 you see. I think you can see my drawing, isn't it?
Yes, sir.
So this is, and see here there is a phase reversal there, just like that in T4 also. See T4 is there. So definite. See here there is a phase reversal at T4. So this is a centrotemporal spike. Centrotemporal spikes are there. I think so. This may be a malignant form of the centrotemporal epilepsy. As you said, progressive to landocorpus syndrome, because it is the previous EEG which you have shown, maybe the
Yes,
continuous spike wave during a slow wave sleep. So
that fully we couldn't get, sir. Even during sleep, everything was sedated sleep only, sir. But continuously spike and wave, we didn't get anything like that.
Yes, definitely. So she is in a state of compound form of complex partial seizure status.
Okay, sir.
And there are reports of a serious morbidity and mortality associated with the complex partial seizure description. It is there.
Okay, sir.
Definitely, that is one of the possibilities here because of the very typical EEG, which has evolved to a continuous spike wave paroxysm. So, if the EEG, if the seizures are not improving with that, I think then we will go for what?
Sir, then seizures is not controlled.
Because it is a CSWS like presentation. CSWS like presentation. So, we'll go for a IV methylprednisolone for 5 days.
At present, now we have started her on IV steroids, sir, suspecting autoimmune encephalitis. Outside CSF was normal, sir. They did on January. Protein 35, sir. Cells minimal, sir. And CSF and serum NM autoimmune panel fully they did, sir. That was all negative only, sir. And both EEGs showed the same right predominant centrotemporal spikes, sir. They didn't start an anti-epileptic. They didn't give steroids, sir. We now started 3rd day of methylpred, sir. 500 mg IV pulse, 3rd day, sir. And we have added valparin syrup also, sir. 30 mg per kg.
But she definitely requires anticonvulsant, you know, so you have to
valparin.
No, you go take the patient to the EEG lab, even if it is sedated, no matter. Then give the IV lorazepam, the EEG table. That is the best method, and see whether these spikes are coming down. Which will come down. It will come down, and then because she is not conscious, we can't assess the behavioral improvement at that time. But if she is, if you can make her lie down consciously without sleep, it will be well and good. So you can feel the difference also. Definitely, I think because she is getting very frequent episodes of unresponsiveness and So these are all episodes of seizures only, and in between she is okay, but in between she is in a behavioral problem. That means she must be in a state of compound form of complex partial status. That is what is being described. This only it is a rare condition, but it is because of the poor drug compliance. That is the major reason described for it. A patient who is on anticonvulsant, but they are not taking it in a proper manner. I have seen this sort of, but the only thing is that it's not continuing for a long time like this. But at least for 2-3 weeks, I have seen cases. We have done all these type of things, and they will show definite improvement. Because if it was encephalopathy, other age, the background should have been abnormal. Background is well preserved here.
This is just a background theta range is there, sir. Not no polymorphic delta. The chaotic background as well, sir.
But that extreme delta and other things you may get only in very few cases, and that too in a typical encephalopathic state.
Hot time delta breast.
Encephalopathy means she must be in a drowsy state, but here it is a behavioral problem. So it is the circuit that is getting affected.
Yes,
So
sir.
definitely the benign romantic epilepsy or as the self-limited epilepsy with centrotemporal paroxysm, they have described this sort of a malignant transformation described and going on like this. So in this case, what you do is you add these 3 drugs followed by clobazam. Clobazam is one of the best drugs. Again, give it a higher dosage. Definitely, I think you can see that improvement. So finally, I think it is a compound form of complex partial status.
Okay, sir. So should we go for any immunomodulation therapy, sir, like IVIG or plasma exchange?
First you complete the
Control seizures.
and try to give good anticonvulsants in a
Dose.
complete manner, complete full dosage. Sodium valproate will be ideal after loading with lorazepam and phenytoin. IV phenytoin will give you a good improvement. In such cases, phenytoin is considered as a drug for status, IV, better response is with phenytoin. So give phenytoin and see the response. And then go for other anticonvulsants and step up to the maximum dose and see the effect. Along with the methylprednisolone. But if no improvement, because IV methylprednisolone will be difficult, IV IG will be costlier, So we can go for that later.
Okay, sir.
MRI also no finding. Anything else in the MRI?
MRI will just show you. Sir, MRI just plain is taken, sir. Contrast is not taken, sir.
So whenever we are thinking of a inflammatory process, always go for a contrast scan also.
Sir, can I show the MRI, sir?
Second.
Sir, plain MRI. Can you, sir, hosting
So I'll make again host.
MES Neurology.
Yes, I will make the host.
Load ಹಾಕಿ. Not yet.
Yes. Now you are the host. Share it.
Okay,
but
sir.
I think all these 5 months only one MRI is taken.
Sir, yes, sir. Previously they tried to take MRI, sir, but they couldn't take MRI, sir. Patient was not at all sedatable, sir. Now she's.
That is not an excuse, Pediatric.
They have tried 5 times or so, sir. That's why the first initial 5 days they tried sedatives, sir. Despite they couldn't take.
She is so hyperactive, so you have to give a stiff dosage of pedicloral. You give
we took MRI, sir. Pedicloral 7.5 ml. She got sedated, sir.
But you should have taken a contrast also. Anyway,
yes, sir, after consulting with you, we thought of taking contrast, sir.
Okay. Continue.
Sir, can you see the MRI, sir?
Yeah. Just go to that ventricular view. Ventricular view again. Lateral ventricles,
Yes, sir.
Go ahead. Go back. Little more up. Just down. One down, one down. One down.
Down, sir. Inferior.
Well, I'm seeing only it's the
Sir.
brainstem. It's the brainstem. I want ventricles with the lateral ventricle.
Okay, sir.
Centrum cervical region.
Okay, sir.
So here the white matter also okay, gray matter okay.
Yes, sir.
Oh, there. Because I thought that there is some raggedness in the ventricle. See, when you, again I'll show you that. I'll just show you. I'll just what do you call, draw it here. See the posterior part of the ventricle. There is some dilatation. The raggedness is there. There's a posterior dilatation. You can see there. So this may be a pre-existing. Was she a normal, 100% normal child, or was she not more hyperactive earlier also? They're telling she was
no, sir.
normal. Okay. But I thought that. January. What was the birth weight?
1.7 kg, sir.
1.7 kg. That's it. 1.7 kg. So there is a periventricular. This is definitely a periventricular leukomalacia case. That is why this posterior region of the ventricle is dilated, and the white matter. You can see that the white matter in this region. See, it should have been like this. So, but it is gone from there. So the ventricle should have been like this.
Okay, sir.
Okay. Do you have any other?
Coronal sections.
T2 flare. Just show the T2
yes,
flare.
Sir. I have flare, sir.
T2 flare you have?
Yes, sir.
Show that. Then I think there will be some amount of sclerosis will be there. Periventricular sclerosis will be there.
This is flare.
Flare. Actually, you should have had a flare axial. Anyway, go. Okay. Go. Little more.
This is.
Okay. See there. That region you see. Did you see there?
Yes, sir.
So that is definitely a periventricular leukomalacia. That sclerotic changes are there. See here, it is periventricular leukomalacia. If you take that axial T2 flare,
yes,
definitely you can see that sort of a finding there.
I'll see if I have axial, sir. I didn't record, I think.
See, this sort of a finding is being described in a GABA A receptor encephalopathy, where you can have a status epilepticus. Prominent cortical and subcortical T2 flare MRI lesions are also being described.
Okay, sir.
Okay, you just read the GABA A receptor encephalopathy. In that, actually, it is being described like that. Okay.
Yes, sir. Okay, sir.
Take the. Now you are actually showing the EEG, isn't it?
EEG, yes, sir. This is.
Take the axial flare, axial T2 flare.
Sir, at present I don't have it, sir. I'll just.
Just look there. But anyway, actually, because of the presence of prematurity 1.5 kg, definitely we'll have to that periventricular leukomalacia is there. So that is a reason where, especially that is in the occipital region. So it is a posterior head region gliosis also is there. Periventricular leukomalacia is there. So that may be triggering the seizure. Okay, that may be the reason for the intractability. But what we are seeing is the centrotemporal region, not in the posterior head region. But again, it may be contributing definitely. MRI have they reported the periventricular leukomalacia?
No, sir. MRI just one or two non-specific frontal. There were one white spots, sir. Very small lacunar white spots.
My question
Malaysia,
is whether
Malaysia, they didn't report. They didn't report, sir.
Definitely it is there. The T2 flare axial you see, already I have shown you in the coronal cuts, but it is there, it will be there in the flare is the best ones to see the periventricular leukomalacia. Gliotic changes you can see there. Definitely it is there. That also will be explaining her hyperactivity, her some sort of a behavioral changes also. So this is when did she walk?
Sir, she started walking even before 12 months itself, sir. She
Oh,
started
that is what
walking.
they are telling. Okay,
Yes, sir.
okay. And no neonatal seizures also.
No, sir. No, sir.
But definitely periventricular leukomalacia is there. It is not just like initially I thought that your EEG very usually we all describe spike and changes, spike and wave changes, especially in the sleep EEGs. But in this EEG, we are seeing a very definite epileptic changes plus MRI showing the periventricular leukomalacia. So this is I think as you said, that child is having a form of an epileptic developmental and epileptic encephalopathy also, but the recent change in behavior must be secondary to the status.
Yes, sir.
I think any other question or any discussion? I think none of the other PGs have opened their mouth. Anyway.
Sir,
Any doubt? Have you understood what are the conditions we have discussed? At least what are the conditions that we have discussed?
one is autoimmune encephalitis. In that there is a NMDR, GABA A, GABA B, LG1, sir. LG1 receptor, glycine.
LGI1, because that is leucine-rich glioma inactivated. That is one protein. That is an LGI1. Leucine-rich glioma inactivated. That is LGI1. I1 means protein 1. Okay.
And anti-AMPA, and then glycine and.
Yes.
Then it could be autism spectrum disorders in that development.
I mentioned about the childhood disintegrated disorder. Read about Heller's childhood disintegrated disorder. Okay, then.
Then it could be epileptic encephalopathy, sir.
Yes.
Myoclonic encephalopathy.
SSP and other variants. Okay.
SSP.
And other metabolic disorders like Ulrich-Lundberg syndrome, Lafora body disease, then neuronal thyroid lipofuscinosis, all the sialidosis, all those conditions we can consider in that progressive myoclonic encephalopathy. Okay, different conditions, including SSP. Then what else we have considered?
Then in metabolic, it could be Sanfilippo's disease.
Sanfilippo. So you read all these conditions, then you will know. And then finally, what was our diagnosis?
It could be by evolving epileptic encephalopathy with the lesion due to source. It could be from the periventricular leukomalacia.
And or a compound form of a
complex partial seizures.
Complex compound and progressive self-limiting epilepsy with centrotemporal paroxysm or a malignant form of a Rolandic epilepsy.
Oh, sir.
Okay, so these are the conditions we have discussed. So you give a IV lorazepam in the EEG table.
Yes, sir.
And try the impact. Okay, then I think shall we conclude then? Yes, doubt on
no, sir.
Did you at least did you able to follow it? What we have discussed? Others?
I think Reddy is we had one case or emergency. He is busy with that, I think, sir.
Oh, that is okay. Who is Dilip?
First year PG, sir. Dilip.
Okay, and so he is not opening his mouth. Dilip, just switch on your microphone.
Hello.
Tell something. What did you learn from today's class?
Sir, I learned about this patient
Okay,
presented with
tell me about the typical autoimmune childhood encephalitis.
NMD encephalitis, sir.
So how does it manifest?
It will manifest as seizure and behavioral disorder, sir. Behavioral disturbances.
Uh-huh. Okay.
Sir.
Okay then. Is that the only manifestation? Seizure, behavioral changes.
Then, sir, aphasia will be there, sir.
No. It is not.
Okay.
It is the extrapyramidal manifestation. It is abnormal movements, choreothetoid movements.
Hyperkinetic.
ഞാനിപ്പോ അങ്ങോട്ട് വിളിക്കാം. ഇപ്പൊ ഞാൻ വിളിക്കാം. Okay, then. Okay, I think you read all these things. Okay,
Okay,
Arun, you conclude?
Okay, sir. Okay, sir.
Okay, then.
Thank you, sir.
Okay.
മുഖത്തൊരു മാറ്റമുണ്ട്. ആ മുഖഭാവം കണ്ണും മുഖവും ഒരു വാടിയൊരു മുഖം. അല്ലെങ്കിൽ കുഴപ്പമില്ല. ആ മുഖത്തൊരു മാറ്റം വരും. അപ്പൊ ഇങ്ങനെ ആയി. ഇങ്ങനെ ആകുമ്പോൾ പ്രത്യേക സൗണ്ടുകളൊക്കെ ചിലപ്പോൾ ഉപയോഗിക്കും. അങ്ങനെയൊക്കെ ഉണ്ടാവും. നോർമലാകുമ്പോൾ ഒരു കുഴപ്പമില്ല. നടന്നില്ലേ, നടക്കുമ്പോൾ സംസാരിക്കുന്നു.
എണീറ്റ് നടക്കടാ.
എണീറ്റുന്ന നടക്ക് നടന്ന
പേരെന്താ? കുട്ടി പേരെന്താ? പേര് പറഞ്ഞുകൂടെ?
പേര് കൈ